नेसरी का अच्छा, फिर उसके बाद
Sir, we are becoming live now.
Okay. Good evening.
Yeah.
Shamshul, can I start? Shamshul?
He has muted himself.
Sir, I'll just tell you.
Live now.
Yes, sir. We are live now, sir. We can start, sir.
Good evening, everyone, and I welcome you all to for ASAMI India third webinar. So this webinar is very interesting, and it is basically on diaphyseal deformity correction. And I request all the panelists to first mute their. Please mute yourself, everyone. I welcome Dr. P.N. Gupta, Dr. Ajay Abrol, Dr. Rajesh Rohilla, Dr. Siddharth Sharma, Dr. Divya Ahuja, Dr. Purav Kansara. They are basically the speakers. They will present one case each. And the panelists are Dr. H.R. Jhunjhunwala, Dr. Mangal Parihar, Dr. Arya Agarwal, Dr. S.N. Reddy, Dr. Satish Nesri, Dr. Jitendra Bhatnagar. So with this, without wasting time, we start our program now. And I invite Dr. Satish Nesri to come and present his first case. Dr. Satish Nesri. Dr. Satish, can you hear me? Yes.
Please go ahead. You are visible.
I think
Dr. Satish,
you have to unmute him.
Your PPT is visible. Please go ahead.
Unmute yourself. Unmute. Ravi?
I've done that.
Okay.
I've done that. I've done that.
Yeah. Can you hear me, sir, now?
Yeah,
Yes,
yeah.
sir.
You can
Yes,
carry on,
you are
Dr.
visible.
Satish.
Yeah. Thanks a lot, sir. Thanks a lot, President ASAMI and all the panelists. And I'll be presenting a very simple case of a uniplanar deformity. This patient is a 19-year-old boy with a 5 months old neglected post-traumatic hypertrophic stiff non-union. So here you can see there is a varus deformity in the lower end of the tibia, and in AP view it is a varus deformity. In lateral view, the deformity is 0. So there are two problems here. One is the deformity, and the second is the hypertrophic non-union. So the solution to these two problems are: one is planning, good planning for a deformity correction, which includes identification of the cora and placement of the hinges and osteotomy site. So for hypertrophic non-union, it's a simple union can be achieved by providing a good stability at the non-union site. So this is how I have planned the deformity correction. Initially, as we know, the tibia, the mechanical axis and the anatomical axis are same. So you can draw mid diaphyseal line in the proximal fragment and the mid diaphyseal line in the distal fragment. The point at which these two axes, these two lines meet is a center of rotation angle, which is known as cora. And the plane, the transverse bisector line, which is seen as a blue line here, it is just a transverse bisector line which bisects the angle made by the two axes into two equal angles. This is a bisector line. This is very important because this is where the axis of correction occurs. That is ACA, angle of correction of axis. So the placement has to be the hinges has to be placed on this blue line. So clinically, how to find out where to place the hinges. So that is also important. Here I am planning for a medial opening wedge osteotomy, which is osteotomy rule 1. So here after correction, both the axis of the proximal fragment as well as the distal fragment is not translated, not altered. They lie in the same plane. So when we place a hinge on the lateral aspect of the bone, so this is how the medial opening is achieved on the medial side. So how to find out where to place the hinges? So the graphical method is a very easy method which can be followed by everybody. It's a very simple method. So you have to take a graph paper, and then you have to, since it's a left leg, you have to place your foot, that is as if your foot is in deformity. You have to stamp on the graph paper, and when we do that, right side will be the medial one, left side is the lateral, anterior and posterior. So before planning, you have to note down certain parameters. So in AP view, the deformity is 19 degree. It is plotted along the x-axis, and in the lateral view, it is plotted y-axis. In this case, the deformity is 0 degree, and in varus deformity, the apex is always on the lateral side. So these parameters are important. In the scale I have mentioned, it is 1 degree per 1 mm. So when we plot on the x-axis the deformity in the AP view, it will come on the lateral side with 19 degree. I have marked it over there. And the placement of hinges is exactly perpendicular to the plane of the deformity. So this red line, you can see, this is the placement of hinges. You have to shift the hinges medially up to the lateral cortex of the bone, because we want medial opening wedge. So here the hinge placement, when you place it on the shin, the line corresponds the space between the two holes, so which is practically not possible. So I have chosen a one hole lateral to the wire fixation bolt. You can see in the right side in the clinical picture, I have placed the hinges. That is, I used a three hole post which correspond to the osteotomy side, that is the non-union side. I placed one hole lateral to the wire that is ring fixation bolt. And next, where to place a motor rod. As you can see in the graph on the right side, this is always the motor rod is always placed on the plane of the deformity. So this corresponds to the two holes, the space between the two holes. So I have either you can choose a one hole above, one hole below. So I have chosen a one hole above, and you can, in the clinical picture you can see on the left side there is a motor rod. So this is how the clinical picture look. And I have done a fibula osteotomy. I have excised around 1 centimeter of the fibula. And this is the post-operative, immediate post-operative X-ray. So I have started distracting medially around 0.25 millimeter 4 times a day. So it took around approximately 3 weeks for the deformity to get corrected. So this is at the end of 3 months, the fracture, the non-union side healed. I have not done anything, just pure distraction and giving a good stability at the hypertrophic non-union side has resulted in the union, and deformity is very nicely corrected. So this is a post-operative picture. You can see the patient is very comfortably walking. He is working as a driver in a poultry farm. So very nice result. So take-home message is single plane deformity can be easily corrected, effectively corrected by Elizarov by gradual method. Hypertrophic non-union just needs a good stability for a union, and the knowledge of osteotomy is very important for calculating the cora, the placement of hinges, and the osteotomy site. Good pre-operative planning is a key to success. Yeah, thank you, sir.
Thank you, Dr.
Thanks for
Satish
allowing
Nesari.
me.
Thank you, Dr. Satish Nesari. And I welcome Dr. Harshad Shah and Dr. Vasudevan, who have just joined in. Now, I request the next speaker, Dr. Purav Kansara, to be ready with his presentation. And Dr. Satish Nesari presentation is open for discussion now. So, any questions or clarification from the panel? Dr. Mangal?
I think this is reiterating the fact that we had talked about earlier also, in the sense that good distraction, just distraction in a hypertrophic non-union will heal it. Satish, I want to ask you one thing.
Yes, sir.
After you have corrected the deformity,
Yeah.
You have essentially only 3 rods. So do you then take off the, put in straight rods and take off the hinges, or do you keep it on?
No, sir. I have not taken out the hinges. I kept only 3 rods. And after correction was achieved, I tightened the hinge mechanism and then allowed the patient to walk. I have not put any fourth rod. So with 3 hinge, I could manage.
But generally, I think I would tend to, make it more stable, because once you've got the deformity corrected,
Yeah.
it stable. So I would tend to change.
Yes, yes. Ideally, that is the way to go, sir. Ideally, 4 rod is more stable than the 3 rod. But at the end of correction itself, there was a very good callus formation. So I thought fourth rod was not necessary.
Yeah, one question, sir, Dr. Satish.
Yes,
Hello?
sir.
Did you do any compression to hasten the union?
No,
After-
sir. No compression.
Okay.
No, sir.
Any comments, Dr. Agarwal, Dr. Junjunwala? Dr. Agarwal?
Yeah.
Dr. Harshad, I think we can't hear Dr. Agarwal. So Dr. Harshad, you can go ahead.
Yeah. Like Dr. Mangal Parihar was saying, I would have put 2 distraction rods from the beginning, parallel to each other, where the resultant distraction comes in the middle, where Dr. Satish Neshri has done an excellent job. He has done.
Thank you, sir.
And you can do it probably like that before weight bearing, and after weight bearing, if you're starting, we generally put 4 rods. That's
Yes.
what we follow. But then
Yes, yes.
Satish Neshri has got a very good,
Hello?
an excellent form.
Hello,
Yes, Dr. Jitendra Bhatnagar. Yes.
Dr. Satish.
Yes, sir.
You have intentionally kept a little bit beyond the lateral apex.
Yes,
You,
yes,
you
yes.
wanted some length to achieve, and that was wonderful. I really appreciate you got the length, you got the union, and because this was a hypertrophic non-union, that
Yes, sir.
probably you have done it intentionally, I think.
Yes. So as we go along when we place the hinges away from the lateral cortex along the
Yeah.
crura, we will get a
Yeah.
lengthening effect.
Yeah, you got the length also.
Yes.
That's really appreciable.
Dr.
Wonderful.
Shamshul, just unmute Dr. Agarwal. I think he wants to say
I've done,
something.
sir. Already done, sir.
Dr. Agarwal,
Yeah.
any comments? We could not
Yeah,
hear you because you were mute. So please, what are your comments now? Dr. Agarwal, we can hear you now.
Yeah, you can hear. Okay. So, Dr. Sati is a good presentation, but I was seeing the X-rays.
Yes,
The
sir.
label of the hinges both are not at the same place, in the anteroposterior view and the upper ligament. So when we
Yeah.
correct the deformity, we should take care of that the labels of the hinges should be at the exact place. That is
Yes,
only
yes.
problem.
Because if the hinges are not at the level, then you get translation.
Yeah.
Yes.
And Dr. Junjunwala, any comments, sir? Dr. Junjunwala? Dr. Junjunwala, can you hear us?
No, sir. He's mute. Let me unmute him, sir.
Dr. Junjunwala is on mute. That's why.
Yeah.
You have to tell him to unmute it.
I've done, sir.
Dr. Junjunwala? Dr. Junjunwala? We can't get him. He wants to, he's raising his hand, but he's not able to, I think.
He has to unmute, no?
No, he's unmuted. No problem.
On my laptop, it is mute.
Any comments by Dr. P.N. Gupta?
Yes, sir. I just have a single comment that some of my cases, when I excised the fibula, some of them they went into a gap non-union. So my preference nowadays would be going in for an oblique osteotomy.
Yes, very correct. Actually,
Dr.
PN,
Gupta,
I
can
also
I
face this
comment on
problem. And if you get a non-union at a lower part of fibula, then it becomes a problem. So I also do a oblique osteotomy. I think that works very nicely.
Yeah, especially
Yeah.
you know,
Yeah.
if it is a varus deformity, you
Yes,
can't go
yes.
in with a transverse osteotomy because
Yeah,
Very correct,
Dr.
very
Gupta, can I tell you? Because we have done a lot of cases, and some of the cases they have got is non-union. You're very right. The osteotomy should be oblique. And second thing, your rate should be very well controlled, because we
Yeah.
correct the deformity very fast. And those cases goes to it is non-union. So we always see by the X-rays that the deformity at the lower 1/4 of the fibula should be very slow, and we should watch for the X-ray callus formation. That is my recommendation.
Any comment by Dr. Rajesh Rohila? Dr. Rajesh?
Fine correction, sir. He has done very nice correction. Uniplanar deformity. He has demonstrated very nice view to correct it.
Dr. Vasudevan, any comments?
Yeah, I have some comment there, especially these cases are being watched by lot of juniors. The hinge is made not by the real hinge. It is made by the male post and the female hinge. Hello, Manish?
Yeah, you are audible, sir.
Yeah, so that is because there are so many people seeing this, so we must show them a standardized method of correcting it. Where to keep the olive oils, how to keep all these things, how to put the hinges, where exactly, and the hinges are not made by male post and the female hinges. It means two female hinges when it is there, or one male and one female. The hinges are designed for that, not post. When you put a
Dr.
post,
Harshad,
it translates.
No, carry on, Dr. Vasudevan.
Yeah, that is the only thing.
Okay. Dr. Harshad had a comment.
No. I want a question.
Yeah, at the end of the
whole
correction,
house. There is a law of triangles which is used when you're distracting in such cases. Does anybody use that?
Yeah, everyone. We always use it. Always use it.
Yes.
And that is the standard. One should use it. That is the standard.
Actually, if you don't follow that,
yes,
then
you are going to create problem.
Lower 1/4 of the fibula, it goes to the non-union. According to triangle also, but wherever you do the osteotomy in the fibula, your speed should be very, very low. By that, you can prevent the non-union of the fibula.
Now, for correcting the deformity, for distraction of deformities, that law of triangle, does everybody use it or not? Was it shown?
Rule of similar
Yes.
triangle must be used.
Law of triangle should be used.
That's called rule of
If you do
similar
not
triangle.
use it, if you distract the rod at 1 millimeter per day, then you will end up in premature consolidation in a lot of cases.
Yes, correct. You will
It
not
has
be
to
able
be
to
more than 1 millimeter per day.
It has to be more than 1 millimeter per day because the rods are away from the leg.
The rods are,
and
agreed.
Generally, it is 2 to 3.
Yeah, usually it comes to in an average adult, it comes to around 3 mm.
3 to 4 tons.
But in
Average adult, it comes to around 3 mm.
Yeah, there is not much problem of the consolidation because always the callus is very, very slow.
Okay. Now, can we go to the next speaker? Dr. Purav Kansara, are you ready?
Yes, sir. I'll share my screen.
Yes.
Can I have one question?
Yeah, sure.
Dr. Manish, I want to know about the hypertrophic non-union. The principle of treatment of hypertrophic non-union is that the compression and stabilization. He is doing distraction.
No. Actually, in hypertrophic non-union, distraction works better.
Yes. Distraction is better, but if you distract it, then you need a fibular osteotomy. Also.
So we have to do fibular osteotomy. We have to do. That's what we were talking. Either you remove.
Actually, sir, there is a shortening of the tibia. So we have to do this.
He did the fibular osteotomy.
Okay.
So basically, for hypertrophic non-union, you have to just freshen it with a small opening, freshen the bone, chip it nicely, and just distract it. It always unites.
Manish, it is better to stick on to deform the correction. Manish.
Sorry?
We are not going to discuss non-unions.
No. He had a question, so we will.
Yeah, we have to discuss the diaphyseal deformity.
Yeah. Chalo, we go to Dr. Purav Kansara.
Yeah, we must discuss that.
Yes, sir.
Okay.
Yeah.
Sir, am I audible?
Yes.
Yeah.
First, I would like to thank ASAMI India for providing opportunity to speak here. I'm going to show a case of femur malunion, which was corrected with rail fixator. So I will discuss the planning, the execution, and the obstacles which I faced during the whole case. So he was a 25-year-old man an obese man, 105 kg weight, and he came with a malunion of femur. So he came to me after 15 months after sustaining a fracture, and his complaints was right leg shortening and difficulty in walking. We will go through the old X-rays quickly. He was operated elsewhere before he came to me. So this is the 2-month post-op X-ray. He had a fracture of femur and same side tibia. We will discuss the femur case only for today. So we can see a bent plate here. It's going for a malunion. This is 10-month post-op X-ray. Good callus formation has occurred, but the plate is bent. And he presented to me with this X-ray. So he had a femur wall union with varus deformity and 5 centimeters of shortening. So that is the axis drawing, anatomical axis drawing. And there is deformity in frontal plane only. The sagittal plane angle is normal. The posterior distal femoral angle is normal. Now, this is the full length X-ray which I got. And I want to say that is this X-ray okay for planning? Is this a true AP X-ray? So we should always see the X-ray carefully. If it is true AP only, then we can plan. We see the shape of lesser trochanter and the femur notch. It suggests that it is in external rotation. So this is the shape of the notch we want to see. And this is the shape which we are seeing on the X-ray. So this is not a true AP X-ray. And we should repeat the X-ray. So I went to the X-ray room and I repeated the X-ray. And now what we are seeing is the shape of the proper shape of lesser trochanter, which is equal to the other side, and the shape of the notch. So I did planning and I used anatomical axis method. And this is the Cora. So I used 82 degrees angle from the opposite side. Now let us see why getting a true AP X-ray is important. So here is the difference of Cora level between both X-rays. In the true AP X-ray planning, we are getting Cora at the 3rd screw. And in the external rotation X-ray, the Cora level is at 1st screw. So it makes a lot of difference. And accurate planning needs a well-positioned X-ray. And at times we have to go to the X-ray room ourselves to give proper patella forward orientation. That is the first message. Let us go ahead with planning. He had a right femur shortening of 50 millimeters and right tibia shortening of 12 millimeters. So where to do the osteotomy? Now we can see that the 3rd screw location is the Cora position. And I want to put the hinge here, but where should I do the osteotomy? What is the ideal location? Can I do osteotomy at this Cora level? I selected not to do osteotomy there and do osteotomy higher up, as shown in the blue line, because I did not want to do osteotomy in the malunion area or near the malunion area. So I tried to go up a bit. And this is the tracing. So this is the osteotomy rule number 2, and we must know osteotomy rule before we do deformity correction. And the rule number 2 is that when you put hinge at Cora and osteotomy away, then translation of osteotomy will occur, but the axis will align. So we are seeing that there is translation between the bone ends, that is translation of the osteotomy, but the axis is aligned. So I want to execute this plan. And I selected to go with the rail fixator. Now just 2 slides on the technique of alignment. So first we have to insert pins perpendicular to the anatomic axis of each fragment. That is, we are putting the pins perpendicular to the proximal fragment axis and then to the distal fragment axis. Then we do osteotomy. And when we correct the rail with the pins, the axis aligns with because of the rail fixator. So we are using the rail as a reduction tool, but we are relying a lot on the pin placement. If the pin placement is proper, only then we will get this correction. So here is my plan. First, to put pins perpendicular to anatomic axis of both fragments, like this. So this is the proximal fragment pin placement, perpendicular, and this is the distal fragment pin placement. I plan 2 clamps for distal fragment. Then I would do the osteotomy and then connect with rail fixator and I would get correction. But let us see what happened. I did not get complete correction and also I could not achieve translation. So I first removed the plate and put pins and then did osteotomy. And there was this post-operative X-ray. So let us discuss why this occurred, why I was not able to achieve the desired correction. So this is showing malalignment, post-operative malalignment. So the reasons might be the cantilever action of the pins. So the monolateral fixator pins may bend and they bend more after distraction or when we attempt correction. And this bending of pin is more often seen in bulky legs because the fixator lies away from the bone in an obese patient. The second possible reason is to failure to put pins perpendicular to anatomical axis. So again, I'll go to the technique slide. Only if we put pins perpendicular to the individual axis, then we get proper correction. So I might have failed to put pins exactly perpendicular in the distal fragment because the geometry is abnormal. It's not possible to follow bone contours as we can follow in the proximal fragment. And the third possible reason why I did not get translation is that I did not follow a rule that we have to do translation first and then do angulation. If we angulate first and then attempt translation, it may not occur. So now what to do? There is malalignment. I've done the osteotomy. The rail is applied. Should I go back to the OT and should I readjust or can I do something else? So I decided not to do anything now, just start distraction and I will correct alignment later before the regenerate heals. So I will correct before the osteotomy consolidates. And I went ahead with distraction. This is 30 days post distraction X-ray. It is showing good callus formation. Still the malalignment is there. At 60 days after distraction, I can see that the axis is still malaligned. And this K wire, which is coming at the knee, it is the anatomic axis of proximal fragment, which shows it is obviously malaligned. This should have been the right location, but it is not seen here. So the technique which I used was acute shortening of the regenerate and change in alignment with swivel clamp. So this is the yellow arrow shows the direction of the shank pins. First, we have to loosen the tension in regenerate, and then we can change the angulation with micrometric swivel clamp or graduated swivel clamp. This is the graduated swivel clamp. So what I did, I loosened the first I gave him spinal anesthesia. And this should be done under anesthesia, and in the CD unit, and then I try to adduct the proximal fragment because it is a varus deformity which I have to correct. And I got this alignment. And this time also I ensured that I get some translation, which was the original plan. And I got 81 degrees of anatomic lateral distal femoral angle. So I locked everything and waited for healing. So the message is that when the bend or deform regenerate is there, it can be corrected acutely by loosening tension and use of swivel clamp as long as it is in soft state. This is the result after 8 months of surgery. Osteotomy is healed and I removed the fixator. This is clinical picture after 1 month of removal and the knee is stiff. The pre-operative range of motion was 90 degrees. At 1 month, this is the range of motion, but is well aligned. And the full length X-ray shows that femur length is almost equal. There is 1 centimeter shortening of tibia. And I think its function is okay with that much of shortening. So another important thing about the rail fixator use, that immediately after rail fixator removal, we don't get much range of motion. So this pre-operative 90-degree range of motion was 0 when fixator was applied. At 1 month after removal, we get this much range of motion, almost 30 degrees. But we just have to wait. And this is the picture at 16 months after removal. He is almost 90 degrees away. So the learning points in this case is that Well-positioned X-ray is a must for planning. We must know osteotomy rules before we do a deformity correction. And we have to mind the possibility of pins bending with a rail fixator or any unilateral fixator, which is described as the cantilever effect. And we should know the technique of acute shortening of regenerate and alignment correction with graduated swivel plane, because many times we may not get the desired post-op correction. Thank you.
Thank you, Dr. Purav Kansara. I request Dr. P.N. Gupta to be ready with his presentation. Dr. Purav, there is a question for you. What was the diameter of the pin you used for LRS?
The 6 millimeter pin. So it is 5 millimeter to 6 millimeter taper pins.
Okay. And any specific reason that you chose LRS for this correction?
Sir, his thigh was so bulky that even her 220 ring was almost touching his leg. 200 was impossible and 220 was nearly touching his leg. So Elizarov was out of question. And internal fixation I didn't use because I wanted length.
Okay. Any comments by Dr. Mangal Parihar? Dr. Mangal?
I think that in the femur, LRS is pretty useful. And as long as you follow this principle of going perpendicular to each segment, I mean, that principle remains whether you are using the LRS or the Elizarov. You would put the proximal set of rings perpendicular to that segment and the distal set of rings perpendicular to that segment, and then you get both of them parallel to each other. So I'm not a big necessarily an Elizarov fanatic, especially when it's diaphyseal. You've got good hold on either side. I think the LRS works pretty well.
Yeah. Hello, Dr. Pura.
Yes,
when
sir.
you allowed the patient to weight bear?
So once I did the final alignment correction, that is loosen the regenerate and I angulated the proximal fragment, then I locked everything and I allowed full weight bearing.
When?
Before that he was just touched on weight bearing.
Hi, Dr. Purao. Hello.
Yes, sir.
Yeah, in the first clinical picture, there is significant rotational deformity.
So I'll come to that. Yeah.
First,
that deformity is at the tibia. I marked that.
Yeah.
That deformity is at
So
the tibia.
actually he has, when the ankle fixator was placed, he says my foot started rotating inwards. When I examined him, this was a cavo-varus deformity of the foot.
No.
Yes, sir. And if we see the full length X-ray, the femur rotation seems to be okay. And tibia also, there is the normal overlap of distal tibia fibula. So he had a rigid cavo-varus foot deformity, which I plan to correct later.
Okay, right.
No,
Dr.
Dr. Kansara. Hello. Dr. Kansara.
Yes, sir.
Will you go to the last X-ray, final X-ray, and have you noticed that there is some hockey stick deformity? Last X-ray, final X-ray, final X-ray.
Yes, sir. This X-ray?
This is hockey stick deformity, which definitely has some amount of rotation and angulation, both uncorrected, and that is not acceptable.
So here the lateral.
You need to go again for the planning. You need to go for recorrection and stick to the principle, just as Mangal told you. Each and every fragment should be right angled. The pin should be right angled to the fragment, and then you need to correct it.
Yeah, sir. But what exactly is a hockey deformity? Because I am able to get the lateral distal femoral angle of 81 degrees, the anatomical angle, and rotation wise also the shape of trochanters is equal.
You can see yourself. This is a hockey stick deformity. It is a not normal femur, as it is a normal femur on the other side. And this is giving some amount of varus.
So, sir, the best way to decide whether a deformity is there or not, I think it is to go by the angles, and the angle was 88 degrees. So, I think, sir, I rely more on the angles than just merely seeing the shape of the bone.
Yeah, can I comment one thing?
Yes,
because
yes.
the lower end of the femur shows varus deformity. How the angle can be 88 degree? Because if you see the femur, there is varus deformity about 4-5 degree. So how the angle can come 88 degree?
Dr. Agarwal,
Yeah.
he has drawn the lines and he's saying 88. And
Yeah.
on the screen, you can see 4 or 5 degrees of deformity. You have to be super expert to see that. The
Yeah.
point is, the varus in the distal femur is compensated by a slight valgus on the proximal side. So ultimately, you draw the lines and the angles are okay. This golf club deformity does not matter. Golf club deformity is very important in case there is no other proximal balance. Here, proximally, if you notice, it is in a little bit of valgus. So if the joint centers are collinear and the angles are right, I don't think this, the so-called golf club, I don't think it makes a big difference.
I have a one observation.
Yes, sir.
Dr. Kansara, I have one question.
Yes, sir.
This whereas deformity.
The voice broke, sir. Can you please repeat?
Dr. Rohila, can I ask one question? Yes.
You ask, then I will ask.
Yeah, one of the problems which I always face in a bulky thigh is that there is a lot of fixatory impingement. So in your X-rays also, the fixator was quite near to the thigh, and in
Yes,
one
sir.
case,
So it was
like. So how do you sort of, and then if you have if you place it too close, then only you're able to get, and if you place it too far, then you're not able to actually get your pins inside the clamps. So any tips and tricks to that?
Yeah. So usually I keep the fixator 2 centimeters away from the skin, but here I had to keep it only 1.5 centimeter or maybe 1 centimeter. So I knew I was taking the risk that it might touch the skin, but the further I move the fixator away, the earlier the bending will occur.
Yeah,
so
agreed.
I was watchful for the skin impingement, and I went at the time of the second adjustment when I loosened the tension in regenerate. I took it away once I was sure that the alignment is achieved. So it is actually closer to the skin, but the reason is to lessen the cantilever action.
Okay, Dr. Rajesh.
I wanted to make one comment that we corrected this deformity with LRS. Is the LRS was appropriate selection of implant in this case?
No, that we have already discussed, Rajesh, that the thigh was so bulky that he was not able to put even 205 ring also, 220 ring also.
Even 220 was very dangerously
So
close.
he was actually. We have already discussed that LRS is not a ideal for this deformity.
I think.
Okay.
Dr. Manis, one query.
Yes, sir.
Dr. Manis, there is some deformity of the distal leg.
I'm coming to that. I was wanted to ask him that there is a deformity
bone fracture of the distal leg, and it is going in the varus.
Yes, heel is going into varus, Dr. Purav.
Okay,
there
so
is a deformity in the lower tibia, plus the heel is going into varus. If you see the clinical picture standing from behind.
Yeah. So that part has not been corrected. So I said initially also, I have decided to focus on the heel at the moment, but I will come to the tibia also. I'll show the first X-ray. Yeah. So this is the X-ray of tibia, and this is actually a medial translation deformity, and the plafond line is perpendicular to the diaphyseal line. So maybe 1 centimeter of translation. So I mean, I would not want to correct this.
Yes.
Deformity.
Yes, Dr. Vasudevan.
And there is a contracture. So the cavovarus. Yes, sir.
Yes, sir. Yes, Dr. Vasudevan. Dr. Vasudevan?
Yeah. Pune, we have done a good job. Congratulations.
Yes, sir. Thank you.
Well done. And the next thing is which pin you are used? Which company?
The Pitker, regular SS pins, sir.
Yeah, because the problem is that the longer the distance between the bone and the clamp and the rail, the pin tend to bend. One trick is you can keep it little angulate, not keeping 90 degrees. You just keep little bit acute.
Yes,
and
sir.
always, as you said, translate it first. translate and displace it first, then correct it.
Yes, sir.
Otherwise,
That
it
should have been
won't
the
give a
right
good
seat.
direction.
Yeah.
And sometimes what can you do? I order specifically a cobalt chromium pins. Cobalt chromium pin is very expensive, but that is very good for these obese patients.
Do you get that long
About
pin?
the tissue reaction, sir, you mean to say for that reason? The irritation of the skin, sir?
Hello?
Hello? Yeah. Dr.
Yes.
Vasudevan, sir. Yeah. So, sir, for what reason?
Yes.
Is it less irritant to the tissues?
No, cobalt chromium is much more stronger.
Okay. Okay.
It won't bend.
One question.
Yes, sir.
There is deformity in the tibia, there is deformity in the femur. What should be the order of correction? Like we should do the distal correction first, then go proximal, or should do the proximal correction, then go to distal. I am not aware if any faculty, senior faculty can.
It is always proximal first and then distal.
Any reason?
Proximal first and the distal later.
I think, can I say something? I think it is a matter of your choice.
No,
You
no,
can go
sir.
both simultaneously.
No, never.
No, sir.
Never.
First, you
can-
correct the proximal deformity.
Proximal first and then distal.
See what is the result. And then according to that, for example, if you have corrected the proximal deformity, there should be 2-3 degree of errors. So in the distal deformity, you will compensate that and you will correct the deformity according to the proximal alignment.
I
So
think
it's a
that
must.
depends on the degree of deformity.
No, sir.
If you
It's
see
a-
a obvious varus in the tibia,
Never.
It's a must. First you correct
so
the
I
Never.
think you can take it simultaneously. I think there is
No,
no
no.
harm
No.
in doing both the
Can
things
I say
simultaneously.
something?
One can go for
that we should go.
one can go for both.
Can I say
But
something?
if distal is
Please, one person at a time. One person at a time, please.
weight bearing has something to do with this, because if there is distal deformity there, then it is very difficult to weight bear. We should go from distal.
But sir, the distal deformity is very mild. I said it is just a 1 centimeter medial translation. So I decided the deformity which would give result earlier.
You have done a good job. I am not. I'm just for discussion purpose that we should. What is the thinking of the house? That's
So sir, once the proximal deformity is corrected, it becomes easier to take X-rays. It becomes easier to make a stable proximal fragment. So that is the first reason I went for the proximal deformity correction first. And the second reason was that it was a more severe deformity. So at least he would be asymptomatic earlier, and at least his life would be easier. And the surgery took so long, it almost took 5 hours. So I didn't do both in a time.
Purav, can I suggest something?
Yes, sir.
Anyway, this patient has been non-weight bearing because of his distal problems. So both can be done simultaneously. Anyway, you are correcting it according to principles of deformity correction.
He was weight
Femur with
bearing.
respect to femur and tibia with respect to tibia with
Sir, the patient is very obese. You can't correct that.
No, he was weight bearing. He was weight bearing
distal
with
end
the
of
both
tibia is not
deformities.
so obese compared to the femur. It won't be a big problem.
So he was weight bearing, but he had a limp. And I don't have the video at present with me. But the only
tibia is
problem was
non-union.
no, it's not non-union, sir. No. Let me come to the final.
Purav,
yes, sir.
Purav, I would like to do the foot correct first.
So
yes,
that
sir.
weight bearing is good.
So once the foot is very well balanced, yeah, the whole alignment will be better.
Okay.
And the femur is already united. You don't have to hurry about it.
Exactly.
That was I was saying
And
that
once the
go from distal to proximal.
the
Like
foot correction
Vasudevan said,
tough.
yeah, like Vasudevan said, one of the principles of whenever you have a regenerate and a non-union, then you need to have weight bearing. It's one of the strongest stimulus for good healing.
Yes,
So you
sir.
choose accordingly. Of course, Purav has done an excellent job and he still has a lot of work to do on this.
So, sir, is my video visible? I'm showing a video, walking video. Yeah. So this is the pre-operative walk video.
Oh.
And I'll show
Dr. Purav, patient has a foot drop also.
16 months post removal walking video.
But there's in the X-ray, there was a cavus deformity.
Chaos and external rotation.
So I think, I mean, he's able to walk with the deformity of the foot also.
But
the deformity is negligible. Doesn't require correction.
Yes, sir.
All right, then that settles the issue.
Okay, just listen.
Very well done, Kansara.
Okay, listen to me. We'll go to the next speaker, and I request all the panelists to speak one at a time, because once we all start speaking, then it creates a lot of confusion. So, who is the next speaker?
Yeah, myself.
Are you ready?
Yes.
So, Dr. P.N. Gupta, please go ahead, and please everyone mute yourself. Only speaker has to keep his mic unmute. Okay, Dr. P.N. Gupta, please.
Yeah, I'm just.
I think I lost connection. I can't hear anything.
Yeah, are you able to hear me?
Yes.
See me? Yes. So I'll go with this patient who is a 11 years old girl.
Sir, your PPT is not.
Sir, please share your
screen,
PPT, sir.
Please share your PPT.
Okay, sorry. Okay. Just a moment. Share. And
Yes, we can see now.
Now you can go ahead
now.
Yeah, just go to the show mode, slideshow. Yeah. Now it's okay?
It is okay. Carry on, please.
Okay. So this girl was 11 years old with the deformity of both the lower limbs since birth and was progressive in nature. So what comes to your mind is either some sort of rickets or a skeletal dysplasia or some other condition. So what the first thing comes to your mind is going for the labs and the radiographs. So these are the radiographs. I will come to that later. It shows a deformity which is almost like a O-shaped deformity. So once you go to the labs, you see that the calcium is reasonably okay. 9 to 11 is the normal range. Serum phosphate levels are 1.9, which are low both in nutritional rickets as well as in hypophosphatemic rickets. Alkaline phosphatase is a shade above normal, but not very highly raised. And vitamin D is a shade below normal. So these are the lab parameters for this child. So once you see a deformity which is shaped like a O, the first thing which should come to your mind is a hypophosphatemic rickets. So what basically is hypophosphatemic rickets? It is an X-linked disorder with a prevalence of 1 in 20,000, with girls more affected than the boys. There are two problems here. One is the problem of conversion of inactive form of vitamin D to active form of vitamin D. And second is the problem of renal resorption of the phosphate. So common presentation is a deformity like this, O-shaped deformity, and it is usually progressive. However, you can have a windswept deformity, whereas there is a varus in one side and a valgus on the other side, which is uncommon, or sometimes you can have a genovalgum deformity as well. So what was done? A deformity planning was done, and I used the anatomical axis. And if you see the neck shaft angle, that is fairly okay. You see the proximal anatomical axis and the distal anatomical axis, we draw an angle of about 35 degrees. And in the tibia, the same thing was 30 degrees. However, the cora was outside the bone. So we split the cora into two by doing a resolution cora, and we had two coras there. So with this planning, I chose to do a LRS for the femur and a Ilizarov for the tibia. So these are the three pins. Did a osteotomy, a lateral closing wedge, and used a rail to fine tune the further correction. And in the tibia did a 2-level osteotomy. One level is here, as you can see, and other level is here. So this is in May 2014. 4 months post-op, the osteotomies appear to be uniting. However, there is a problem on this side. And 6 months down the line, still the union is not full to solid enough to remove the fixator. And finally, after 6 months, the fixator was removed once the osteotomy is consolidated. And once we checked the angle, we were fairly okay within the range of medial proximal tibial angle of 85 degrees. The ankle angles were also okay, and the anatomical angle was 85 degrees for the femur. However, there is a little translation of the axis on the femur laterally. Rather than the line going medially, there was a little translation. So the problem which was faced in this patient was that though we allowed the child to go to school with the external fixator, but the school authorities refused to entertain the child to the school. So patient was not comfortable with the external fixator for a long period of time, and then loss of school hours. So similarly, we thought we on the right side we go in with the internal fixation. So we did this. We did this 2-level osteotomy in the tibia. However, we ended up in a little varus on the right side in the femur. So this was the clinical result. Left side reasonably good, but right side still you have a varus. So second surgery was done on the right side with the distal femur corrective lateral wedge closing osteotomy, and this is the result at 2 years of follow-up. So what the literature says, in hypophosphatemic rickets, since there is some sort of lateral thrust and a lateral collateral ligament laxity, the mechanical axis should be mildly overcorrected at surgery. And the recurrence rate, especially in the younger children for the relapse of the deformity, is around 90% for the first procedure and 60% after a second procedure. However, this relapse rate goes down once the child is skeletally mature. To minimize the relapse, one has to go in for a active vitamin D analog, that is alpha calcidol, where the metabolism is bypassed in the kidney. I mean, the kidney secretes one alpha hydroxylase, which converts the active form of vitamin D to inactive form to active form. And along with that, because of the renal tubular leakage of phosphate supplements are also to be given along with that. So what we found was that in these cases, there is a delay in regenerate consolidation. But the lessons learned from this case was that the external fixator allows fine tuning of the alignment. Intramedullary fixation or plating is an alternate option. And younger patients have a higher risk of recurrence. So I'll quickly go to another case. I'll quickly run through this case. This is a 16 years old girl with a similar deformity. So we did the planning and we did with a internal osteotomy and an internal fixation using nail, using the anatomical axis plan. And this is after the correction of the femur, and subsequently we went for correction in the tibia. With this planning, again the cora was outside, so we went in with 2-level osteotomy, and this is the correction. And on the left side we went in with a similar procedure, and this is the left side. And finally, at the end of 6 months, everything united. That's the left side, that's the right side, that's the left side, that's the right side. And similarly for the femur, that's the left side, that's the right side. And this is the clinical picture of the child. Now child is, I think this girl has grown up and is pursuing a medical stream. So I thank you all. I think we are open for discussion.
Dr. P.N. Gupta, there's a question for you from my side.
Yeah.
In the first case, why did you not choose? You chose anatomic planning for the femur. Why did you not choose? Because your osteotomy level was quite low. You should have chosen the resultant cora for the femur.
Yeah, I chose that. If you see this,
it's quite down. If you see the bend is up, you could have.
No, bend is somewhere here. If you see, bend is somewhere here.
You could have done your osteotomy slightly up.
Here.
Because anywhere on the third line, the line which is the third line, it would have straightened.
No,
and
this one. This is the neck anatomical axis.
No, the resultant line connecting.
No, this is not the resultant. This is the anatomical axis of
Because
the.
I personally feel in your femur, the lines, there should be two coras. What I personally feel that in this.
Yeah, there can be. I mean, you can do a resolution cora, but then that
Because
would
I
not have
think the
given
lines are not drawn properly because there should be at least two coras because there is a bend. So usually in a bent femur, femur like this, you always get two coras.
Yeah, in the tibia we got two coras,
You got
but in
two
the
coras,
femur,
but femur also you would have got two coras if you would have drawn, because always in a C-shaped deformity you would get two or multiple coras.
Yeah, we checked it 2 or 3 times, but the cora was coming as single. So we thought we'll go in here.
Okay. Any question? Now this is
Yeah.
open for the panelists. Dr.
Dr.
Agarwal.
Gupta, yeah, I
Yes.
want to ask you because whenever you the ricket cases, so we always see that the alkaline phosphatase, serum phosphorus, and serum calcium become normal.
Yes.
Because if we do not do that, so we may have a lot of problems there. Because we check that
I
everything
agree.
become
This
normal.
actually both these cases, they were hypophosphatemic rickets.
Yeah.
So in these cases, you have to give active form of vitamin D, which is alpha calcidol.
Yeah.
And because normal vitamin D will not work, it will not get converted to active form in the kidney. There is a 1-alpha hydroxylase deficiency in them. And second thing, what we learned was that you need to give phosphate oral solution as well.
Yeah.
So both were done under the supervision of the pediatrician.
Yeah.
Dr. Gupta, why you have chosen?
Yeah, we always do the
Dr.
alkaline
Gupta.
phosphatase also.
Yes, sir.
Yeah.
I have a question.
Yeah.
There is a medical problem with hypophosphatemic rickets. The
Yes, sir.
anesthetist will not give anesthesia. Pediatrician won't give permission. So if
No,
you want to do repeat
that's-
surgeries, you have to be very careful. By that time, it becomes difficult. They say it is very risky.
No, it's not. Basically, we have treated around more than 15 odd cases of, and in all these cases, we go in for proper pre-anesthesia checkup, and none of the cases we had a problem.
Okay, Dr. Ajay Abrol, you be ready with your presentation. We can have few more questions to Dr. P.N. Gupta. Dr. Ajay, can you listen?
Yeah, one of the things which I wish to highlight here is that in all these cases, we had a delay of consolidation, maybe around 5 months, 6 months in some of these cases. So you have to counsel the patient pre-operatively that this fixator needs to be in for a longer period of time. Usually we expect around 3 months, but all these cases we removed the fixator a little late.
Dr. Gupta, can I tell you?
Just Dr. Agarwal, 1 minute. Dr. Ajay Abrol.
Yeah, I'm ready.
Okay, Dr.
Hello.
1 minute. Yes.
One question.
Yes.
Yeah, first is Dr. Agarwal, then you.
Yeah, Dr. Gupta, nowadays we are doing the fixator-assisted plating. That is very common. I've been seeing in the United States also.
I'm doing it very
Because for a
regularly
longer
nowadays.
time, yeah.
These
Because
are
for a
older
longer
cases, yes.
time, it's difficult to have these cases. Sometimes they become the loosening of the pins there. So fixator-assisted plating is now very popular. So
I
I
agree,
think
sir.
in the future we can do that.
I agree. I have been doing this. These are older cases, so I've been doing it very routinely now.
Yeah.
Hello.
Yes, sir.
Harshad, now when it calls Dr. Harshad.
Yeah, my question
Dr.
is
Manish, can you listen me?
joint movement.
Dr. Anupam.
Dr.
One
Anupam,
question.
you come to the different channel from the other side. This is faculty.
No. Can you listen me now?
Yes, we can listen to you.
There is one question. There is some differences in opinion of doing osteotomy age-wise in adolescent. What are the dictum to the osteotomy in the earliest in the adolescent age in femur or the tibia, varus or valgus deformity around the knee?
No, I didn't actually get your question. Can you repeat that?
The in the adolescent age, the patient having a post rickets deformity or by any cause of the deformity, hypophosphatemia or anything, the age to perform the deformity, to correct the deformity.
Yeah, earlier stage to correct the deformity.
Yeah, earlier stage to correct the deformity.
Yeah. So
and both side at a time, unilateral or bilateral at a time.
Okay. So your question is that whether we should go unilateral or bilateral, number one, and what is the earliest stage you can correct the deformity?
Earliest stage you can go for.
Yes. It all depends on where the cora is. If the cora is near to the growth plate, somewhere here, then you can consider a growth modulation surgery, and usually that is done bilateral if the deformity is bilateral. However, if the
Doctor.
deformity is in the diaphyses or away from the growth plate, then it has to be osteotomy. And in hypophosphatemic rickets, what literature says is that in case of mild deformities, which is not been quantified in the literature, that means if the patient is not
Dr. PN,
Not
we can't
audible.
hear you. Dr. PN.
degenerated joint disease does not occur.
Yeah, just
Okay, now, please, 1 minute. Dr. Harshad, your question, please.
Yeah, it was about knee joint movement when you do simultaneously for femur and tibia.
Yes.
What were your results? Because I had a very...
They had, no, it's good. It was good.
Okay, any final comments by Dr. Mangal Parihar and then Vasudevan, Dr. Mangal?
No, I think they've covered all.
Okay, Dr. Vasudevan, please.
Yeah, most of these hypophosphatemia rickets, they have a torsional deformity.
Yes.
That you have not mentioned.
Yeah, I think I just forgot to mention, we corrected the torsion in the distal. Most of the times they have a torsion somewhere here. So what we do is we go in for an acute correction of the torsion correction with the Ilizarov or the internal fixation. Yes.
What about the
Dr. Gupta, Dr. Gupta, Dr. Gupta, please.
Yes, Dr.
Yes,
Jitendra.
Dr. Gupta, why you have chosen this anatomic access planning? Why you have gone for mechanical access planning?
Yeah, these were very old X-rays, and some of these X-rays we were doing with the conventional X-rays. And
did you do any
Dr. Jitendra Bhatnagar.
The two reasons.
Yeah.
The two reasons. One, that in a child, the proximal femoral mechanical axis is not too clearly defined because the tip of the trochanter is not clearly defined in the child. So this is one reason.
In this case, it was defined. It was visible.
No, Dr. Jitendra Bhatnagar, I will answer this question. Actually, in this C-shaped deformity in the femur, it is one of the places where anatomical axis planning is better than mechanical axis. When there is a bent femur, C-shaped, everywhere else mechanical axis, but specifically in this situation, if you do a anatomic axis planning in a bent femur, it is better because when you can see multiple cora and you can then draw the resultant cora. So anatomic axis planning is good in C-shaped deformity. It's the only place where we do it. Otherwise, mostly we use the mechanical axis.
No, I have done so many cases, and their mechanical axis gives you very perfect result.
You can do it, but this is one place when there is a C-shaped femur. Anatomic axis planning is better than
gives a better cost message as well.
Yes, I agree
one
with
thing
you.
I will add. Pele's book says that anatomical axis planning in femur is much easier than mechanical axis planning in femur. So in femur you can
eventually it is the same. Eventually both the things, the end result is same.
So he says that anatomical axis planning, you can go with anatomical axis planning in femur as per the Pele book.
Okay, now we go to Dr. Ajay Abrol. We are having short of time. Dr. Ajay Abrol. Dr. Gupta, please stop your screen share.
Yeah.
Dr. Ajay Abrol. Dr. Abrol, can you hear us?
Yeah, I can hear you.
Dr. Rajesh, you be ready. The next person to.
I'm ready, sir. I'm ready.
Okay, after Dr. Abrol.
First of all, good evening, all the panelists. So I'm presenting a case of diaphyseal deformity of the leg. So here's a 26 years old male presented with pain and multidimensional diaphyseal deformity of the leg.
Not seen, no? Your screen.
So
Ajay, we can't see your PPT.
You can't see a PPT?
No, we can't see your PPT. We can hear you, but we can't see your PPT.
Sir, first open your presentation, the background, sir. Then share from Zoom.
Dr. Abral has become very old in all the technology.
Yeah, Dr. Abrol, minimize your Zoom, open your presentation, and then maximize your Zoom and do the screen share.
Okay. So that's what I was doing.
Yeah, now it's coming.
No, it's not coming now. Shamshul, please help him.
Sir, have you opened your presentation and background, sir?
Yeah. I've opened. Yesterday I was doing it.
Okay. You can close the presentation again.
I have to close it now, I think.
So we can go to Dr. P.N. Gupta. Sorry, P.N. Gupta is done. Dr. Rajesh Rohila by time being.
I can start it.
Yeah, Dr. Rajesh, you go ahead.
Yeah, you do. I don't know what happened.
Is my screen coming?
Yet coming, sir. Not loaded fully.
Yeah, PPT we cannot see. Yes, we can see now. We can see now. You can go ahead.
Okay. This is the case. Good evening to all of you. This is the case of osteomyelitis tibia. Patient had osteomyelitis tibia. Presented to me at this stage, 10 years old male with varus deformity. Then I applied this simple external fixator cum distractor, did the fibular osteotomy, K-wire fixation of the fibula, and external fixator cum distractor, and pin. You can see the pins are in the distal small fragment of the tibia. Then slow correction of the deformity with fixator cum distractor. Then did the corticotomy to bridge the bone gap. And once the bone was transported, I open the non-union site and refreshing of the bone ends, docking, and reinsertion of the distal ring wires. The frame was added in the foot to correct the equinus deformity, and ultimately it united. The patient came with severe valgus deformity in tibia after 1 year. And then I did the planning of the deformity. We know this whole of the planning, do the mechanical axis deviation, and then measure the ML distal femoral angle, MPTA. Then you should do the small orientation test of the ankle, because sometimes the deformity may be in distal tibia near ankle joint, which was in my case. And do the proximal mechanical axis, distal mechanical axis, where they intersect, that is cora, and decide about the uniapical or multi-apical deformity. The difference between multi-apical and uniapical deformity is, if you do the osteotomy at resolution cora, then there will be zigzag anatomical axis. The mechanical axis is corrected, but anatomical axis is zigzag. So you have to do the two osteotomy at the true coras, so that the anatomical axis is also corrected. Then we all know that open wedge, neutral wedge, or closed wedge correction. So coming back to my case, this is the you can see the mechanical axis is passing way beyond the joint. So there is valgus deformity in the limb, and when we measure the MPTA, this is more than 90. So this comes out to be valgus deformity of the tibia. So if you do the this mechanical axis femur is normal, you extend this line distally, so becomes the proximal mechanical axis of tibia, and this is this mechanical axis. You see what I was telling. This is 76 degree lateral distal tibial angle. It should have been the 90 degree. So you have to mark the distal tibial angle at 90 degree. So this is at the 90 degree, and it is intersecting outside the bone. So once the cora is outside the bone, then either it is a multi-apical deformity or it is translation deformity. So you have to plan now the middle axis segment. So middle axis segment is this. So this is intersecting proximal axis here. This is true Cora 1, and this is intersecting the distal axis here. So this is true Cora 2. So this is the 2 osteotomy solution. If you do the osteotomy only at single resolution Cora, you can do the single osteotomy solution. I chose the 2 osteotomy solution, did the 2 osteotomy, one proximal, one distal. I did the primary correction close wedge osteotomy at the operation table only, but did some final correction as an open wedge correction later on. So we do the scanogram in between the, you can check the correction, though it is the scanogram is done little bit later date, but it can be done between the correction when you are doing the gradual correction. Ultimately, the correction was done and full consolidation of the union just before fixator removal, and ultimately the union in correction was achieved. This is, I will quickly go through this because it's similar case. You can plan the 2 osteotomy or single osteotomy. In this also case, I did the 2 osteotomy, corrected the deformity. After 1 year, I did correction the single osteotomy with SUV, and this is the 8-year follow of this girl. This is the right side is with SUV, and this left side is with this conventional laser out technique correction. So take off masses. We can use the simple fixator cum distractor to correct initial severe planar uniplanar deformity, and fibular osteotomy fibulectomy is required to correct the severe deformity in tibia. And planning is most important, as deformity may be multi-apical. You have to choose between single osteotomy or double osteotomy solution, and double osteotomy solution avoid zigzag deformity. So thank you for your patient hearing.
Thank you, Doctor. Dr. Mangal, your comments, please. Dr. Mangal.
Yeah. Rajesh.
Yes, sir.
Second child.
Yes.
Why didn't you use growth modulation? She has enough growth remaining.
Yes, we can use the growth modulation, and this is about 10-year-old case. So at that time, I probably discussed with you, and I go for the osteotomy.
Okay, Dr. Ajay Abrol, are you ready?
Yeah, I'm ready, but
no, we will take few questions now. Hello? Are you ready now with screen share?
Hello, Dr. Rajesh.
I have a question.
Sir, yes, sir. Yes, sir.
Hello.
Here, very good cases. You have done it very well. But what I feel is, on one side you have done SUV, on the other side the iliaceral limb looks straight. The SUV limb looks crooked. You have done a
you nicely.
Please remember, SUV is not the answer for everything. Your pre-operative planning and a double osteotomy in that SUV case also would have been probably better.
Yes.
There is a deformity still remaining in the other limb. SUV was done, whereas where you did 2 osteotomies, the limb is straight.
This is I wanted to highlight. The 2 osteotomy gives the perfectly straight limb because it aligns the anatomical axis. 1 osteotomy, you will have some mild deformity, but ultimately the alignment was good.
The alignment was
once
understand what I'm telling.
Dr. Rajesh. Dr. Rajesh.
Dr. Jitendra, 1 minute.
You have done a good job, but in the first case, why you have not equalized the limb first before taking X-ray?
Equalize the
both the limbs you could have equalized.
Block method.
Hello, you have not equalized your limbs when you took X-rays of the first case.
Scanogram is the block method you are saying?
I know. We have done everything, but even in that case, you should have equalized. Your pelvis is tilted. That is why you have more valgus at the distal end, and that is why your correction is little bit odd. And you could have done equalization. Otherwise, that would have given you exact figure. This is the basic principle. One must always equalize the limb. and pelvis should be horizontal, and then all you should take the X-ray.
You are
However, your second case was wonderful, and just as Dr. Shah told, I mean, we could have gone for Lizero in both the leg. It is really good.
Yes, yes.
Okay, Dr. Srinivas Reddy has a question. Dr. Srinivas.
One moment. I did not say you should have done Ilizaro in both the lower limbs. I said the pre-operative planning, whatever is best, then you can use either Ilizaro or SUV. You're going to get the same result.
There were two reasons of doing.
More important than the fixator. Please try
There
to.
were one reason of doing one osteotomy. When I was doing the visceral correction, I have mentioned that there was some healing problem, both of the wound and both of the osteotomy in the distal tibia. There was healing problem in the second case. So I later on realized that I can go with single osteotomy, but there was some healing problem in distal tibia in second case.
Yeah.
Okay, Dr. Srinivas Reddy.
Yeah, Dr. Rajesh, hello.
Yeah.
In the second case,
yeah.
the second case, if it is due to growth plate anomaly, there will be recurrence of deformity. After 8 years also, you said there is no deformity.
Yes.
Yeah.
I believe that this was not due to growth plate problem. This was due to diaphyseal type of mode problem.
Okay.
I believe. And at that time, this is a 10-year-old case, and at that time I discussed with the expert Dr. Mangal Parihar, and this planning was actually sent by him. I probably think.
Okay.
As far as I remember, this is because this was a diaphyseal deformity. Probably at that time, which was he thought that osteotomy will be a better solution.
Okay, thank you, Doctor.
I have a question. Sir, I have a question.
Yes, 1 minute, Dr. Nesri, 1 minute. Dr. Ajay Abrol, are you ready?
Yeah.
Okay, Dr. Nesri, you can ask one question. And then go to Dr. Ajay Abrol.
Yes, sir. So this question is for Dr. Manish Dhawan sir and Mangal sir. In case of a C deformity in the tibia, that is bowing of the tibia, when you want to use a ortho SUV, so how will you plan it? I just want to know.
See,
so we are doing a 2 osteotomies and putting a ortho SUV. So we cannot.
I'll answer this.
Yes.
See, whatever you use SUV or anything, your planning has to be done. SUV is not solution that it's a virtual ring and you will forego your planning. So you have to plan it. Now in tibia, the anatomical and mechanical axes are same. Okay. When there is C deformity, I find it very easy to take the resultant cora. See, I use one diaphyseal line up, one down, and connect these two lines. And in this resultant cora, in that third line, you can do osteotomy anywhere. The leg will get straightened up with translation. So always follow. It becomes easy if you follow resultant cora rather than doing 2 osteotomies. You can do 2 osteotomies also, which we were doing it, but resultant cora is quite helpful.
So when we do 2 osteotomies, how do we manage with ortho SUVs?
No, that's what I'm telling now. You don't have to do 2 osteotomies. If you do on a resultant cora, so 1 osteotomy is enough.
So when you plan to use the ortho SUV, better to go for a single cora.
Single osteotomy with a resultant cora.
Manish, if you are doing 2 osteotomies, one proximal, one distal, you will have to use a separate SUV.
Yes. Yeah, that's what I want to.
So life becomes.
We cannot use 2 SUVs. Can I add something?
1 minute. See, Satish, your life becomes easy with the resultant cora. You don't have to do 2 osteotomies. That's what I'm telling you. So you can do it with this case with a single SUV. You don't have to require 2 SUV at one cora up and down. So a single SUV, but whatever you do, you have to plan first.
No, if you have to do 2 osteotomies, if your planning is better for 2, I think you should use 2 SUVs.
Can I add something?
It's okay, but Dr. Harshad, I disagree with that. You can get away with the resultant cora. It is.
I want to.
Can I add something?
Yes.
Yeah, I just wish to add that two SUVs are nearly impossible in a small space.
Yes.
Because the rods they will impinge on each other, and it won't be possible for you to use two
Dr.
SUVs.
Mangal for final
Dr.
comment.
Mangal may be having more experience.
In the tibia, doing one osteotomy, you will, from a big C, you will make two small Cs.
Yes.
And that can be visible. In the femur, just like he showed, like Ian showed, that is hidden. So there you can use a resolution cora. Now, Satish's question as to, can you use two SUVs? Theoretically, you can use two SUVs, but practically it is very, very difficult. So what I would suggest, if you have to do it, is use hinges, because usually these are uniplanar deformities. They are not oblique plane also. You can use simple hinges on the top and the bottom and correct it, just like Rohila showed. And then once you have got it corrected, if you need to fine tune it, you put an SUV wherever you need to correct it. That correction will be done in a couple of days. Finish it and put straight rods. So
One
yes,
small question, sir.
Everybody
Sir,
kind of,
one question is here to Dr. Mangal Parihar. Sir, if the patient is having the rotational deformity in the femur and lower side, and there is a mechanical deformity, angular deformity on this proximal side, how will you manage with a single cora?
in that cora, you can correct the rotation as well as the angulation. There
Means
are ways to
double
do
correction.
Yes, both you can do. There are two ways to do that. Somebody showed, I think PN showed acute rotation of correction and then gradual distraction to correct the angulation. That is one way to do it. Or if you use a 6-axis system, you can do both of them gradually.
Okay. One minute. We are falling short of time. Can I tell Dr. Ajay Abrol to start? We will take questions after the presentation because time.
One simple question, sir. Doctor, I have learned a lot from Dr. Mangal, sir, and he said that you did not do the growth modulation, but I want to know, was this option in this case, in second case, from Dr. Mangal, sir?
I think so. In such a young child, because there's a lot of growth possible, you can correct quite a large amount of deformity.
This was a diaphyseal deformity type or more epiphyseal?
The diaphysis ultimately is coming from the metaphysis, from the epiphysis.
Okay,
So
sir.
it will correct if the epiphysis is otherwise healthy.
Okay. Can I request Dr. Abrol to do the presentation? Dr. Abrol, we have half an hour only. Dr. Abrol. Okay, we can see your screen, Dr. Abrol. Dr. Abrol, can you hear us?
Yeah, can you hear me?
Yes, we can hear you. We can see your screen also. Please continue.
Okay. So I'll be talking on diaphyseal deformity of the leg. So it's a case, 26 years old male was presented with the pain and multidimensional diaphyseal deformity of the leg. And it was diagnosed as hypertrophic pseudoarthrosis with the deformity in both the planes, AP and lateral. So this is pre-op planning. So the deformities were 35 degrees in frontal plane and 16 degrees in sagittal plane. So the varus was 35 and procurvatum was 16 degrees. So here are the calculations to find out the plane of deformity, hence to find the placement of hinges. So the calculations were that the hinge should be at 6th hole and 9th hole. So from the book, we can see the placement of hinges at the convex side of the deformity to get open wedge. And in our case, you can see that this, sorry. You can see the hinge axis is visible, is passing just close to the convex side of the deformity. So this is perioperative planning on the limb, and it is confirmed on C-arm using cautery wire. So we constructed a proximal two-ring block and distal two-ring block. I always do progressive assembly. I don't use this pre-assembled frames, and I prefer to use all wire fixations. So here in this here you can see the hinge axis. Both the hinges are the line of which is connecting both the hinges is passing through the cora, and you can see the distraction rod uh, 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 very clearly. And this slide is during the distraction, and this is the result at the, this is after removal of the fixator. This is the final result. And here you can see proper consolidation and deformity correction and alignment of the limb. So the take-home message is one should determine cora and magnitude. True frontal and sagittal plane X-rays of the limb are very, very important to do exact calculations. It's very clear that oblique plane deformity is not a biplanar deformity, but it is a plane somewhere between frontal and sagittal. So calculate the plane of deformity and find the exact placement of hinges, that is hinge axis. Thank you so much.
Thank you, Dr. Abrol. 1 minute, 1 minute, 1 minute. Let me speak. Thank you, Dr. Abrol. I request the faculty to use the raise hand option. Please do not speak in this thing. Raise hand option is there at the bottom. Participants, if you go to participant, you can use the raise hand question. I request Dr. Divya Ahuja to be ready with his presentation so that we take questions with Dr. Ajay Abrol. So, Dr. Anil Mahajan, you can ask your question now.
Dr. Ajay, I have not seen full-length X-rays in your planning nor the results. Why so?
Full-length X-rays?
Yes. The distal tibia is not being visible in any of the X-rays.
Distal tibia?
Yes, ankle joint is not there.
Yeah, I don't have.
Even not in preoperative planning also. It should be there.
No, it was there in preoperative planning. It's an old case. I don't have. Maybe I have that, but I have not used in this this presentation.
Dr. Ajay Abrol, the now recent teaching is that any deformity you correct, you have to do a full length.
That I know. That I know.
With a magnification marker. So the message we have to give it to the audience that always take a full length X-ray with a magnification marker. You can have a ball placed on the strap on the X-ray, and now everyone has a digital X-ray. It's easy because there is a stitch program with a digital X-ray, so you can do all can do full length X-ray. So planning is only after full length X-ray. So this is the message I want to give to the audience.
Nowadays we are doing scanogram, a whole scanogram, whole body.
You can do scanogram also. Yeah. And now any other faculty who wants to ask the question? Dr. Mangal, your comment, please.
Dr. Abrol?
Yes.
Yeah, have you done this fibular osteotomy for this case or not?
Yes, yes, yes.
Where, what is the level?
No, it was the same level where there was a non-union at tibia. There was a malunited fibula. So we just osteomatized that.
Actually, Ajay, I think the fibular osteotomy should not be at the same level.
No, it was I think that I don't remember this thing, but I think this fibula was also not united.
Okay. Dr. Mangal, your comment, please.
I think this is again a good illustration of stiff non-union, distract, restore alignment. So when you distract it, restore stability. And yes, ideally, you should do a full length, but it's not mandatory for a shaft like this, in the sense that this obviously is an old, see, this is not even a digital X-ray, this is much older. So yeah, I wouldn't, you know, the limb is for practical purposes straight, so I wouldn't complain too much about it.
Any other question for Dr. Ajay Abrol? Dr. Divya, are you ready? Dr. Divya Ahuja?
Yeah, ready.
So you can, Ajay, stop
Ajay.
share. Yes, Divya, you can start now.
Stop sharing.
Yes, good evening, everyone. Now we're talking about the malunited femur fracture, where we treated this with the fixator assisted nailing. So he was a 43-year-old male, had presented with pain in the left knee, which was about 6 months duration. But he had a distal third femur fracture around 30 years back, which was treated conservatively, and it had malunited in varus. There was overriding and procurvatum, along with around 3 centimeters of shortening. That is his clinical picture showing the malunion. Notice the translation and overriding in the sagittal plane. Notice the lateral thrust when he's walking, mild lurch, and a short limb gait. So when we did the planning, obviously the LDFA was abnormal. There was around 34 mm of shortening, and the translation very well visible on the sagittal view. Now in the lateral view, also notice that there's no real hyperextension or flexion deformity at the knee joint. So when we did a planning for doing the correction at the resolution Cora, now this is not at the obvious deformity because there is a translation deformity in the sagittal plane as well. So when we do this angular correction at the resolution Cora, the discrepancy reduces by around 20 mm. So only coming to within limits of 1 centimeter. So the options now are either do a deformity correction and lengthening at the resolution Cora using the LRS fixator, or do the same thing with Ilizarov and ortho SUV. So patient was a doctor and he wanted early resumption of activity, and the fixator would pose difficulty in dressing up formally for seeing patients. So he wanted an innovative solution. So the plan then was to do it in 2 stages. Stage 1, we will do the fixator assisted correction using the ortho SUV. And stage 2, then we splint it internally with a nail or a plate. First choice being a distal femur, a nail. So the advantage here for the nail would be that it would cut down on the fixator time, and the downside would be possible infection from the pin sites. But since we were going to keep the fixator only for a short time, the risk of infection anyways is a little lesser. So these are the surgical steps. We create the drill holes and recreate the fracture, make stress risers for that, then connect them with the osteotome. Now, when we were doing the osteotomy, oblique osteotomy, then there was shattering at the osteotomy. And though we did notice some translation intra-op, I will come to that later. Post-operatively, these were the X-rays. This was a two ring frame. We used TSF rings because we wanted a little sturdy fixation. Just using the 2 rings, and this was going to be used for a short time. the post-op pictures. And this was the ortho SUV plan, showing the angular correction in the coronal plane as well as correcting the translation in the sagittal plane. So the plan was made for 15 days along with the distraction of 15 mm because just correcting the angulation, the discrepancy was anyways getting reduced. But at the end of 15 days, we noticed there was bending of the pins, and on the sagittal view, the translation was not correcting. So probably either the osteotomy which had shattered had healed, or it was not complete at all, so not allowing for the translation. Though the angulation did correct in the coronal plane, so we decided to stop the distraction at that, give him 5 to 7 days of rest, let the pin sites settle down, and concentrate on knee range of motion so that we don't have any trouble while doing the nailing. So for the nailing, the plan was we will distract on table and see if the osteotomy is complete or not. If not, then we will complete the osteotomy. And for the guide wire entry, we will have to go slightly posterior and medial so that we can get the valgus. Also use polar wires to guide where the nail should be going. So we distracted on table, but the osteotomy did distract a little bit, but was not complete. Then we completed the osteotomy and then made the distal entry for the nail. So the entry for the nail was standard approach, midline patellar splitting, and we use this OHP tracing to use this guide, use it as a guide on the C-arm screen for helping the entry at the correct angle, which was chosen as 81 degrees here, which is the distal femur anatomic axis. And the distal track was prepared. The distal ring was then removed, and we retained the proximal ring to aid manipulation and help correct the translation. But when we were passing the guide wire into the proximal fragment, the guide wire was slipping, kept on slipping posteriorly. The canal was probably also blocked because of the malunion. So at that point, to direct the entry into the proximal fragment, do not hesitate to open it minimally with minimal disturbance of soft tissues, and ensure a central placement in the proximal canal. That will ensure maintaining the correction. We did a little percute opening, that is the fixed reamer passing into the proximal fragment centrally. Once that was done, then all the pins and the proximal ring was removed. We reduced the malunion, passed the guide wire centrally, and noticed that the translation was still not really happening. So that posterior spike was blocking the translation. So broke that, corrected the translation, and then went ahead and did the regular distal femur nailing. But when we were impacting the nail, we had also jammed in the osteotomy. So in the post-op X-rays, the correction was maintained, but the shortening had not got resolved. So keeping in mind our goal of angular correction as well as length, correcting the length discrepancy, we went ahead and wanted to revise the proximal locking. So we waited for 48 hours, let the inflammatory process settle down, and took out the proximal bolts. And with manual traction, we were able to distract at the osteotomy site and then locked it again. And this is after revision of locking. So the picture on the left is showing the overriding, and picture on the right has showing the overriding has reduced. And when the full length X-ray we measured, the length discrepancy has been reduced to just 7 mm. So which is well within the limit of 1 centimeter, and he should not have any issues with the gait. So this is 1 month post-op. Healing is then progressing well, and he's doing very well in terms of function. He's got good knee range of motion at 1 month. He's almost weight bearing as tolerated, just using the walker for minimal support. And then he continued to do functionally really well. But then on follow-up X-rays, we saw that the fracture line was a little visible, and we did a CT scan at that time because of the oblique nature of the fracture line. So it was not clear it's healed, not healed. So the CT scan was showing non-union at the osteotomy. There was minimal loosening around the nail. So we were, there was no real issue with the function. He didn't have any pain at all at the osteotomy. The gait is good. The thrust has gone away. And then we did a exchange railing at that point with the thicker and longer nail. We used this time a synthase retrograde female nail, which allows for 3 locking bolts distally and just approximately 1 dynamic lock. For the biology, adding biology at the non-union, we drilled the non-union side percutaneously and did the reaming up to 13 to push out the reamings through the drill holes. And whatever reamings came out with the reamer heads was added in percutaneously at the non-union side. This is showing the 3 distal locks in the distal fragment. And we also impacted the non-union side before doing the proximal dynamic lock. And 6 months post-exchange, everything seems to be going on well. Functionally, he didn't have any issue earlier also. And we did a CT scan again to confirm that the healing is completed this time. And just a small lateral cortex defect, but otherwise 3 cortices have very well healed. And he continues to do functionally really well. So the lessons learned here was if the goals are clear, then we should, if we encounter troubles in between, we should be able to have a plan A, plan B, plan C to go ahead and correct that. Keeping it simple would be a better idea. A complex osteotomy may not always really work. So just a simpler correction with fixator would be enough. And a percutaneous approach to enter the proximal fragment to achieve a central placement is really a tool in hand, which helps us to get the alignment correct. So thank you.
Thank you, Dr. Divya, an excellent presentation. Dr. Siddharth, please be ready with your presentation. We can take questions from Dr. Divya. Dr. Siddharth, can you hear us?
Yes, sir, I'm ready with my presentation.
Okay, now Dr. Divya's presentation is open for discussion, and I request faculty to use the raise hand option so that I can rope in one by one.
Manish.
Yes, sir. Yes, sir.
I would like to suggest we may run short of time. Let Siddharth present first, and then we can take questions for both Divya and Siddharth together.
Very fine, sir, because we are actually short of time now. We have only 15 minutes. So Siddharth, can you first give your presentation?
both the questions can be asked immediately. You know, we can have one question now and then remaining, so that I don't want him to lose out on the presentation time.
Dr. Siddharth, are you ready?
Yes, sir, I'm ready with my
You
case.
can start your screen share. We have one question for Dr. Divya. One question to Dr. Divya from the faculty.
Yeah, Dr. Shah here.
Yes, sir.
Can you hear?
Yes, sir.
Osteotomy which was done, we do get comminution, but here the comminution seems to be very large. Can you tell us the reason?
So probably our stress risers were not enough. It was much more sclerotic bone than expected. We generally make 3 stress risers and connect them, but probably it needed a larger, more number of stress risers and span the whole area of overriding. That would have been a better option. The other options in such a scenario can also be a clamshell osteotomy, which can work better to correct the angulation and translation.
Yeah, Dr. Divya, we will take more questions after Dr. Siddharth's presentation because we are falling short of time. So your lecture and Siddharth's lecture will be open for questions. Dr. Siddharth,
Yes, sir.
please start now.
So thank you, Dr. Manish, sir, and I will be presenting an upper limb case. And this is actually a neglected adult Montegia injury. So this is the case of a 20-year-old female who had a fall 5 months back. She did not seek attention then, but then she presented to us like this with a non-union of a Montegia fracture and frank fracture dislocation with severe restriction of flexion, extension, as well as rotations. So like we talk of the true views in the lower limbs, we also have the true views in the upper limb. And one of the points that I would like to bring here is that the true view, the true AP and lateral view of the elbow is very different from a true AP and lateral view of the forearm. So in this slide here, you can actually see a true AP and lateral view of the forearm, whereas this is the true AP and lateral view of the elbow. Now, which one should be important for planning this case? I will be touching on this later. So obviously the options were to either do nothing, which is what the patient did not want at all. She came seeking surgical correction. And then if we did choose to operate, what should we do? Should we correct this deformity acutely? Or should we offer gradual correction by means of an Elizra? So the patient had researched all the options really well. She was convinced that Elizra would work. Well, I am a deformity surgeon, so that would be my go-to option as well. And the patient and me, both of us decided that gradual correction, you know, through a lengthening or a gradual lengthening of the ulna would be the way to go. And as we would lengthen, angulate the ulna, the radial head would reduce. We could possibly need a bone graft later for, you know, if the non-union site was not uniting. But then I also told her, look, if this does not work, we may still need to go back to an open reduction procedure. We may have to do acute lengthening of the ulna and a radial head relocation. So with this thing in mind, we chose the Elizarov option, me and the patient. So now there are 2 ways that you can do gradual correction. And I discussed this case with one of my very eminent seniors, Dr. Altaf. So whether we should do a pure posterior angulation with a little bit of lengthening or plan it like an oblique plane deformity. So in this case, we actually chose to plan it like an oblique plane. And as you can see here, there is a 45 degrees lateral angulation on the AP view, and there is a 16 degrees anterior angulation on the lateral view. So once we chose to do the oblique plane planning, again, we were faced with a dilemma. So should you correct it with hinges like you would do in so many other cases that you have seen here? So you can put the hinge along the axis of the deformity, put your motor and correct it out. Or the strategy that we chose is, should you do a differential distraction? You know, the concave side of the deformity is the shorter side. So you can differentially lengthen, you know, just lengthen the concave side and hopefully you should get the correction. The reason why we chose soft tissue distraction with lengthening hinges is because we felt that this would be more forgiving, you know, and like Dr. Altaf said, that distraction and angulation should do most of the job. So with this planning, we went ahead. So how did I plan this case? Well, this is a cross section of the forearm, and I planned it like you would plan any other case. Those are the axes. This is the 16 degrees anterior angulation. That's the 45 millimeters lateral angulation. So the final magnitude of the deformity was 43 degrees, and the plane was 20 degrees from the mediolateral. But in this case, since I was not going to be putting hinges and putting motors, I simply chose to put 2 hinges on the concave side because that's the shorter side, and then 1 hinge on the convex side. So on the convex side, I would be lengthening only 0.25 millimeters per day, whereas on the concave side, the shorter side, the distraction would be 0.75 millimeters per day. So in effect, this would be a differential distraction. So this is the immediate post-operative X-ray showing placement of the hinges. So the distraction was going on. We did get ulnar lengthening. The radial head seemed that it would reduce, but then this happened. So 2 months down the line, the patient had pain. We got X-rays and we found that the distal radio-ulnar joint had dislocated, and this was causing painful abutment. So at this point of time, I had to give up the Elizarov. I did try to go back a little, but then the radial head would not stay. So the frame had to come off. And you can see here, this is the initial angulation. That's the final angulation. So some correction has been obtained, but the surgery itself is a failure. I could not get the radial head to reduce. So then with this thing, then we had to go for the plan B, in which case I did an open approach to the ulna, angulated it posteriorly, got in a bone graft, put a plate. I approached the radial head through another cocker incision. There was no interposition as such, and as soon as I could angulate the ulna, I could get the radial head to reduce. I did not do a soft tissue distraction. I pinned it in place with radiocapitular K-wire. So at 6 weeks post-op, it's already started to unite. The radial head location was stable. She got back her range of movements, but then she was left with the painful ulnar abutment. So for this, then I decided to do a Milch shortening osteotomy because of the length that she had gained. So the shortening osteotomy was done. Now this is a recent X-ray that she's just sent me a couple of days back because of the lockdown. I'm sorry for the quality, but the radial head is stably located. The ulnar length has been restored. You know, she does not have any impingement right now. That's her flexion, that's her extension. And this is a small video showing the pronosupination. As you can see, she has full supination, but then if I move ahead, she does have restriction of pronation, and she can only go up to a mid-prone position. Going further is, not really possible for her. And I would want to see her in the post-operative period. So what lessons have I learned from this case? So lesson number 1, should I have used the true forearm views or the true elbow views? Well, in hindsight, I feel I should have used the true forearm views because I was anyways going to plan an osteotomy of the ulna. Now, mind you, since I chose a soft tissue distraction rather than a hinge, it was a little bit forgiving. But then the true forearm views was really the way to go here. The other bit is, should you go for a pure posterior angulation distraction or an oblique plane planning? Well, again, the lesson that I learned here is that a pure angulation distraction would have probably corrected the radial head subluxation. It would have avoided too much ulnar lengthening and the DRUJ subluxation. The third important bit, which so many other people also told me, is that the DRUJ should have been pinned. But then there are so many other people who said that this force is so great that the wires can bend and break. But yes, if I do a case next time, I will sure pin the distal radio-ulnar joint. And finally, the big question, if I had another case, would I do an Elizarov or not Elizarov? Well, I would have to take that call with the patient. But now I also think that a single stage angulation distraction osteotomy could also work very well. And I would still go ahead and decide on a case-to-case basis, but I would not write off the open procedure in favor of the Elizarov. Thank you. So I'm going to stop my screen sharing here.
Nice presentation.
Hello.
Thank you, sir.
Hello, Dr. Siddharth?
Yes, sir.
Yeah, this is similar to the Olier's disease, where there is high riding radial head. Olier's disease.
Okay, sir.
Yeah, then in that we fix the distal radial ulnar joint and we'll distract the osteotomized ulna, proximal ulna. Yeah, in such cases, the radial head will fall into the normal position.
Right, sir.
Okay,
Yeah.
sir. I want to comment on that, Dr. Siddharth. So we have done the applied the osteotomy of the ulna, and gradually from the lateral side we have, as Altaf told, that there is a very good paper on that. So we
Yes.
have tried to correct the angulation on the medial side, so that the space, the head of the radius was coming gradually downward. So we thought it can be reduced, but we were not able to reduce that because we were having a lot of angulation and everything. Gradually, there was a callus formation in the ulna. So what we have done, when we have done the lot of distraction, we have opened that head of the radius because the annular ligament was not allowing to bring the fragment in the original position. But it was very easy because the head has come down. Only the eye, when I opened, I found out the annular ligament was not allowing that. So very easily we have corrected that, we have put that, and after that we have thought, because we have done more angulation on the medial side. So then we thought we are producing another deformity of the ulna. So after reducing that, we have put the KVR, we again put the nail in the ulna, so that the deformity was corrected. We were fearing that the head of the radius may be redisplaced, but it was not redisplaced. So
Okay.
we have corrected the deformity. Now there is no deformity of the ulna, and very easily we have put the head in the socket. So it is a good technique which we have done.
Can I ask? Dr. Divya, you said that we should keep this it safe and simple. You have managed the case very well. In hindsight, you can see that there were some difficulties. If the same case comes to you now, how will you manage?
I would, rather than the oblique osteotomy, I would prefer a clamshell osteotomy, which will allow me to correct that translation.
You will use the nail again?
Yes, if the patient demands so.
Okay.
Nailing is a pretty safe option here, and it will cut down the fixator time. The issue was not the osteotomy not being complete enough, and the plan not falling through. So the case is not presented to highlight how we nail it after fixator. This was that yes, if you make a plan, there can be mistakes, and how should we go ahead and correct those.
Okay, can I come in? 1 minute, 1 minute. Can I come in? Dr. Shamshul has a case to present, so I will tell him to be ready with his case. Small case, 5 minutes, and now we can take questions.
Yeah,
Okay.
Dr. Divya, can I ask one question to you?
Retrospectively, can we consider that we should check the osteotomy under CM on the table only?
Yes, sir. We did check it. The usual dictum what we follow is we will put in a osteotome at the osteotomy and twist it with a spanner or a plier and ensure that it is translating. Because the osteotomy had shattered, it did show some translation, but it was probably happening somewhere else rather than at the anterior cortex.
Yeah, Dr. Divya, can I ask you, because it was a 30 years old malunion.
Yes, sir.
So that the 30 years old had all the inside sclerosed.
Yes, sir.
Usually there is no cavity. So in these cases, when you have tried to put the nail, it's very, very difficult. Number two, when you have put the nail, you have manually, you have distracted the fragment. That has gone into non-union. So the every complication which is recommended has been done in this case. Then again you have done the nailing that. You have put another nail. So my question is that whether it is, you know, that is a closed bone. You should not put the try to nail. And second, manual distraction always leads to the non-union.
Especially in nailing.
I will answer.
Siddharth.
Manual traction was given only the distraction which we had lost.
That is why we did it early. And this was not a fracture we created and then distracted it. The distraction force was already applied using the fixator, and it was done gradually.
Okay, Dr.
Siddharth,
Yes.
Siddharth,
Yes, sir. Yes, sir.
would you like to do an open correction of the same case, what you did, instead of doing by laser?
Sir, that's a very difficult question. But yes, I would definitely consider. So I do love Elizra. I would want to try again. But yes, considering the problems that I have, I would also favor an open procedure. But that
Yeah,
would
that will
depend
be
what me
rather
and the
better
patient decide. Yes.
Dr.
because there
Bhatnagar,
was not much of the shortening.
Dr. Bhatnagar, it's a very, very difficult when you do to open correction of the head of the human, this radius, because until unless you do not give the distraction, it's a very, very difficult to do the open reduction of the head of radius. When you do the distraction, head comes downward. Only the problem is you cannot reduce without opening the head of the radius because annual ligament break does not allow. So I
So,
think a open reduction you cannot do.
sir, I
Okay.
agree with Dr. Agarwal because I've also done a few of these cases open, and yes, it is a lot of struggle. Yes, you do have to reduce the radial head, and you know it is not a pretty surgery at all. So that's why I also chose the Elizra. But having seen the case yourselves, I mean, none of the options is a simple one. That's what I feel.
Okay, can I come in? I have taken time extension, but we have to first take Dr. Shamsul Huda's presentation because he's the most important person. Suppose we don't give him time, then this will not work. So after him, we will take questions. The whole panel will take questions. So Dr. Shamsul Huda,
Yes, sir.
please
Thank you, sir.
go ahead with your presentation.
So I'll just put a very short case and show 4 minutes, sir.
Hello? Good evening, yes, చెప్పండి.
Diaphyseal fracture, sir. It was treated somewhere.
ఇప్పుడు వస్తాం మీటింగ్ లో ఉంటుంది. ఇప్పుడు చేసేస్తాం రండి.
And after plating, the shop got infected. There was pus discharge and plate was bent. Plate was removed and the patient came to me in this position with this deformity, possible femoral deformity. It was an oblique deformity.
Anil?
I first went for an
45,000 total packet అనేది దానికి.
Faculty to mute. Please mute yourself.
So my first part is please do scanograms in all the deformities you get. I calculated all the deformities on Bone Ninja app. That is my usual routine.
So you are not audible.
Hello, sir. Can you hear me, sir?
Yes, sir. We can hear you.
You are audible. You are audible.
Okay, sir. So I calculated the deformity on Bone Ninja app. The frontal plane deformity was 24 degrees and sagittal was 30 degrees. So it was an oblique plane deformity. So I calculate all the ligament deformity. There was a pelvic tilt also. So skipping all the basics of deformity corrections, you must know all these basics, sir. You must calculate the MAD, the pelvic tilt. We must map the ABC in all the deformity cases. So that measures the mechanical axis deviation, analyze the joint angles, pick the deformed bones, apex of deformity, bone cut, and correction. So here the LLD was around 2 inches, MAD was 3 centimeter, GLC was normal, bone was to be femur, apex of deformity was frontal 24 and sagittal 32 degrees, bone cut, the osteotomy millimeter was defined. Correction was I selected for gradual opening wedge osteotomy with lengthening. So I had option of nailing Elizra or hexapod. So because since it was a history of infection, so I didn't choose for nailing. So it will also cause shortenings. In Elizra for proximal femur deformities, placing hinges is very difficult. So I went for hexapods. I calculated all the pre-plan on the Bone Ninja. Skipping the hardware part, we must know the have knowledge of MUDEF. I calculated all the software on this. I think my presentation is stuck, sir.
It's not moving?
It's not moving, sir. You need to wait few seconds, sir.
No problem. I will take, I will give some comments by the time you make it sorted out. See what Dr. Shamshul has told. He's a very high-tech person, but I tell you this Bone Ninja is a very handy software which you can buy it online. It is from Baltimore, where this course is done. The deformity correction course is done every year. So it is a very handy stuff, and it is I think very cheaper than TraumaCat. So once you are doing spatial correction, Bone Ninja is very useful. So I request people, all the audience, they can make use of Bone Ninja. You are Dr. Shamshul, are you okay?
Dr. Samsul,
Yes,
please
sir.
minimize it. First remove it and then again get in.
Okay.
Dr. Dhawan, I just wish to add that this requires an iPad only. This works on iPad.
Yes, very true. It requires
Yes, sir,
iPad.
Can you hear me, sir? Yeah.
It requires iPad.
Yes, that was accurate, sir. It is the iPad only app, sir. So I made a preform for ortho SUV. I applied did the osteotomy. The patient could walk from the next day. This was the post-operative X-ray for deformity and osteotomy. I'll calculate it with this software. All the calculations were done. I did the correction in around. Stuck again, sir. Sorry. Yeah.
You can show the
Yes, sir.
final X-ray. Yeah.
Okay, sir. The correction was done.
राजू जरा ऊपर चाय के लिए बोल देना यार.
Please mute yourself.
कहाँ की गई?
Please
बस
mute
चाय के
yourself.
लिए बोल देना यार अभी तो 10 मिनट का.
This was after the correction. I removed the SUV and put the patient on rail fixator because it was a little bulky for the patient. After I saw the consolidation was there. It is hanging, sir. Sorry. This is the final X-ray, sir. The patient has not yet come for removal. After removal, I'll be doing a scanogram again, sir.
No, it looks very good, and it is the use of technology. Why did you put this LRS at? Why not continue with SUV?
Sir, patient was having because of proximal femur, patient was having difficulty in identification, sir.
No, but
so he requested for.
Once you get correction from SUV, and when you change it to LRS,
Yes,
you
sir.
can lose your correction.
Yes, I could do that, sir. Agree, sir.
I agree that it is difficult to apply SUV in the proximal femur. That is very agreeable. But sometimes what happens when you change, you can do the correction with SUV because now
Yes,
you
sir.
have changed your pins. The pin now is all uniplanar, so you can lose correction. If you can,
Okay, sir. Okay, sir.
what you could have done that you could have removed SUV and put normal threaded rods initially.
Right, sir.
So that
Right,
could
sir,
have made it less bulky. Now all last three presentation are open for discussion. Dr. Divya's presentation, Dr. Shamshul Huda's presentation, Dr. Siddharth's presentation. So Dr. Mangal he was raising his hand before your presentation. I request Dr. Mangal to please ask your question or comment. Dr. Mangal.
No. I wanted to say for this Siddharth's case, open osteotomy is a well-described procedure with very good results in the literature. So I don't think there is any doubt whether open osteotomy works or not. It works, and it is published, which is to say that not to say that Elizarov does not work. Altaf, who he talked about, Altaf in the last ASAMI meeting showed some good results with doing it with the Elizarov. But the point of the matter is that open also works. ऐसा नहीं है कि open does not work and Elizarov is better. No, the Elizarov is really indicated in certain cases where there is no other option. Here, yes, you can.
Dr. Mangal Priyar, can I talk about this?
No, one sec. Let me finish. Here you can say that the what do you call the scarring, etc., incisions, etc. That is all fine. But the literature, if you look at the literature, there is ample evidence that late presenting Montigias up to 2 years old can be reduced by open surgery.
Yeah, Dr. Mangal, can I say something?
Yeah.
Yeah, Dr. Mangal. You are hearing my voice?
Yes.
Yes, yes, Doctor.
Yeah, actually, we have done a lot of open reduction, open osteotomy. But in the last, we came to know it is a very, very difficult procedure to put the head into this socket. When we started to do the Ilijara, we have done 4 or 5 cases. Then you bring the head downward. Then only it is possible to reduce the head. I don't say that we bring that, you don't reduce it, but it is very, very easy. But I tell you, it's a disaster to do the open osteotomy, put the whatever literature say. We have tried a lot of cases. Ultimately, we came to conclusion that it is a disaster to open the osteotomy, close, open and acute reduction. So I don't agree
I
with
want
you.
to respond to that.
What?
Whatever literature says is not a way to dismiss literature. There are n number of good surgeons who have published. So if they have done it, you can't just discard that.
Yeah, I tell you, because those surgeons which you have they published, they were not knowing the technique of the Ilijara, because there are very few surgeons in the world who know the Ilijara. Once you know the Ilijara technique, you will not do that technique.
Dr. Agarwal, I disagree with you. Dr. Agarwal, I disagree with you. It is not that for deformity only Ilizarov has to be done. The principles are same. You can use any modality, but principles remain the same.
I mean to say, if you do not know the Ilijara, how you can say that Ilijara is better? Because there is very few surgeons in the world who are
Achieve the
doing the
goal. If
Ilijara.
you can achieve the goal either by Ilizara or by other fixation or by open methods, you can choose whichever you know best. Difficult
But you don't do
none of them are easy, but you can still
if you
achieve
do not know the Ilijara, how you can see that?
You can get
Dr. Agarwal, Dr. Mangal Parihar is a Ilizarov surgeon, and he is also doing deformity correction with plates and nails. So the basic point is that for our young audience who are watching the TV, that you have to follow the principles, and whatever modality is good in your hand, you can use that if it is acceptable, because literature is there, and you can use that modality. Yes, Dr. Rajesh Rohila, for your comment.
I wanted to comment that if the ulna is not comminuted, if ulna was transverse fracture and it has only malunited, then we can go for the this simple open osteotomy, and once you will correct the ulnar malalignment, head will come on its own. If ulna is shortened due to comminution, then I think we should go for the Ilizarov type of operation. I think.
Sir, can I make one comment, please?
Yeah.
Yes. So I studied up this case quite extensively before operating, and the issue is not whether we can get the radial head to relocate. We can do it easily, or we may struggle. There may be obstructions. The issue is that of a stable relocation. So quite a few of these cases tend to redislocate when they start forearm supination, pronation. So a lot of soft tissue procedures have been described with the open ulnar osteotomy. Now, Bell-Tossi is one of the classical procedures. And the issue with the soft tissue reconstruction of the annular ligament is that it either becomes too tight and you tend to lose supination, pronation. So yes, so unless you are a guy who has done maybe 20 of these procedures, for a person like me, maybe who has done 4 or 5, to be completely honest, I would view both options, the open and the Ilizarov, with a certain amount of caution. So those are my comments, sir. Thank you.
Yeah.
Any other question from the, you have to raise, the panel has to raise hand and should not talk together. Any question from the panel? Anyone?
9:15.
Yes, I have a comment.
Yes, Dr. Gupta.
Yeah. See what the basis of chronic Montigia in, I have a lot of experience in children. What is the basis of chronic Montigia in children is that you align the ulnar, you do ulnar osteotomy, and you sort of try and recreate the anatomy and sort of do a little overcorrection of the deformity. That means if you are in a that's an anterior Montigia, you angulate the ulna a little more posteriorly so that the radial head remains stable inside. So I think same principle can be applied for adult. And lot of times in children where it's difficult to control these fragments, I've gone in for a fixator assisted internal fixation.
Okay, and one question for Dr. Shamsul Huda. You, in your presentation, you had told that this case was infected.
Yes, sir.
So what did you do for infection? Did you
Sir,
explore the area before applying SUV, or what did you do?
Yes, sir. I saw the patient at the time the patient came to me. There was no infection. The patient had history of infection when the plate was on, sir.
Okay. Okay. And one question for you: whether if there is infection, would
Yes,
you
sir.
like to do corticotomy at that last time? And I will ask Dr.
No,
Bhatt's opinion also for this.
No, sir.
It's a active infection. I'm talking about active infection. Would you like to do corticotomy there?
No, sir. No,
First
sir.
of all, you have to open the site of the infection.
Exactly, sir.
If there is any sequestra, anything that you have to remove.
You have to remove, sir. Yes, sir.
Dr. Mangal.
Remove that
Dr.
then
Mangal.
Yeah. Yes.
Sir, actually, I want a message to the youngsters, because I have, yes, Ilizarov says that infection burns in the fire of regenerate. But I have actually burned my fingers in 2 cases that I did corticotomy in active infection away from the site, but it got infected. And infected corticotomy is a real mess to handle. So, your opinion, your experience, what does it say?
No, I think today 80% of the time I will do an osteotomy at the same time as I have done the debridement. But that's because I'm confident of my debridement with many years. I don't think there is anything wrong, especially in the early years, to do osteotomy 2 weeks, 3 weeks after doing the debridement. It's not wrong. It's not. It doesn't show that you're not a good surgeon. It's just to be safe. So I don't disagree with doing it separately, but today I tend to do mostly together. But for someone who's starting out, not so sure or not very, what should I say, confident of the debridement, till you have shown yourself that, okay, my debridement, once I've debrided it, there's no infection later on. Till then, you can do it separated. No problem with that.
Okay, that's good. So basically, point is that you should know how to handle infection. You have to develop confidence, and then you can do it at the same time. Any
Exactly.
other question for from the
We
panelists?
do a lot of errors. So we decide based on our experience, like Mangal said, that if you want to make an error, you do your osteotomy later than on the same time. It's always better like that.
Okay, Dr. Vasudevan, any comments on the presentations done, all the presentations? Yes.
You have mentioned that corticotomy infection. No? I generally hesitate to do osteotomy on an infected nail patient immediately.
Okay.
Infected nailing, because the medullary canal is infected and it can spread, your regenerate can leak out through that.
Infected nail is something else because the whole cavity is infected. But you have an infected non-union and something femur plating is done and something else. Infected nail is something else. But usually sometimes we are having the pouring pus. So osteotomy, corticotomy should be done later on. That is my opinion.
We have time for 2 questions only. Anyone who has question from the panel, please raise your hand. Any of the panelists for any of the lectures? Or any comment?
Yeah, my comments. All cases were excellent. Thank you, everyone.
Okay, no, I know they are excellent cases. And actually it was a mix of cases, because we had a upper limb case also, and Dr. Divya showed a different modality of trying to correct a deformity with a nail.
And how you saw. Most of them did very well.
Manish.
Yes.
Manish.
Yes, sir, tell me.
Hello. In fact, as far as that hockey stick deformity, which was Kansara showed, it was some amount of translation was also there, and that has added to the without regulation, and that is why there was a deformity.
Yes.
Can
Dr.
can I
Kansara,
say?
any
Yeah.
comment on this, what Dr. Jitendra Bhatnagar is asking?
Yeah, so now we are talking about two things. One is the apparent shape of the bone. The other thing is the actual mechanical axis and malalignment. So the goal of any deformity correction is to get the hip, knee, and ankle collinear, number one. And number two, all three joint lines, that is the hip, knee, and ankle, they have to be parallel to the ground and each other. So that what I said, that is the ultimate goal of any deformity correction described in Dr. Drawer pelvis too. And at the same time, we can disregard the visual appearance of the bone, like that Shepherd Crook deformity or whatever it is. So I think I've been able to bring the identical alignment to the normal leg, and I already showed the angles for that.
It's not the point to correct the angles, it is the point of overall correction, because you have you are talking of drawer belly. He will not accept that deformity at all.
So
Because I
no,
have word with him.
Kansara had that deformity because it's a earlier malunited fracture. And you have corrected at a different level.
At a different level. Simple. That is what.
That is the reason.
In femur, it is
No
acceptable.
problem with the deformity. This is like the Indians who go abroad practice Indian traditions more religiously than the Indians who stay behind in India.
Yes, very true. Any other question? We can take one question or some discussion. We have 5 minutes. Any questions from the...
Everyone is ready to run off.
Yeah, but we had a brilliant discussion.
ऑफिस में आज तू ऑफिस में मैं ऑफिस में हूँ.
No, but we had a brilliant discussion and lot of message for the young audience. And I personally feel that so many people will be motivated to take up Ilizarov and not Ilizarov to learn the basic principles of deformity. So once you know the basic principles, you can use any modality where you are confident. It is not necessary that you have to do Ilizarov, SUV. Dr. Divya has shown excellent deformity correction using a nail. So you can do that. So you can use a plate also, you can use a nail also. The message is that learn your deformity principles and then decide. And always take a full length X-ray, do the planning, draw the angles, and then move forward. Anything else, Dr. Mangal?
No, thanks Manish for keeping everybody under control.
Yeah, but we were actually going out of control. So from next time, we'll be very, very, strict about it. So we meet next week now. Dr. Shamshul.
Okay, sir. With your permission, I'm stopping the live stream, sir.
Okay, please stop.